Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual. And today, again, more important rules. Rule number 117. Document what you said, not only what you did. So we all know documenting is very important. It's very important for patient care. So if the patient comes back, everybody knows what happened in the last encounter. It's very important for medical legal reasons. It's very important for billing so we can get paid for what we did. It's very important to document what happened, procedure, if the patient deteriorated, that we addressed it early, addressed it right away. We need to document to protect ourselves. But documenting your anticipatory guidance or what you said is equally as important. So a good example is when I see a patient that came in with foreign body ingestion, usually it's a coin, I get an x-ray, I usually show the parents the x-ray and explain that the coin is in the stomach and it only has one way to go. I personally don't recommend looking through the stool or through the toilet to make sure it's out. It only has one way to go, and I always make sure they know exactly what to come back for. So if little Johnny now has abdominal pain, vomiting, blood in the stool, vomiting blood, maybe there's some complication related to the coin and you should probably see us back. All of this is very important to document. Again, if you provided good anticipatory guidance, give yourself the credit for it. Under this specific circumstance, with this specific chief complaint of a foreign body ingestion, I also take a minute to talk to the parents about the possibility of worst case scenario. So usually I say something like, Mom and Dad, if little Johnny is the kind of kid that does that and puts things in his mouth and swallows them, please make sure you never have button batteries at home. Button batteries that are ingested can be a serious surgical emergency. Beads, coins, usually no big deal. But if little Johnny ever swallows a button battery or puts it in his nose or in his ears, he can end up in the operating room. This is something that maybe is not intuitive, but in my opinion, has to be documented. You discuss with the parents what can be the worst case scenario in the future. Give yourself the credit for what you did and document not only what you did, but also what you said. Rule number 118. Be wary of the unilateral symptoms. And remember, bilateral is usually better. So a few months ago, I saw a sickle cell patient. I see a lot of sickle cell patients in our department who came in with bilateral leg pain and inability to bear weight. The resident presented the patient and he said, as expected, Dr. Ivan, his leg pain is bilateral, more likely related to his sickle cell disease. That presentation made me think about the following rule. Be wary of the unilateral symptoms. I think it's important to keep in mind that usually it's hard to have some serious surgical etiology for anything that is bilateral. Certainly there are exceptions to that, but I expect a sickle cell disease patient to have bilateral pain. I expect a patient with growing pains to have bilateral pain. Anything that is bilateral, just statistically speaking, is unlikely to be serious. Bilateral eye pain and bilateral eye symptoms are usually secondary to allergic or infectious etiology, whereas a unilateral symptoms can make me think about maybe corneal abrasion or something that is a little bit more serious, such as orbital cellulitis, for example. Same thing with bilateral abdominal pain. I think it's hard to have a surgical abdomen when your left side and your right side are equally as tender. Surely there are exceptions to that. In the right age and with the right story, bilateral leg pain may make me think about bone pain secondary to leukemia. After all, a 3 and a 4-year-old should not be having growing pain. So certainly there are exceptions to that rule, but generally speaking, anything that is bilateral to me is more reassuring. Again, I think it's hard, almost impossible maybe, to have something serious being bilateral. Another good example is the teenager who comes with bilateral knee pain. Surely in a teenager, especially around the knee, I always worry about osteosarcoma or some other bone tumors. Osteosarcoma would be the most common one, but I think it's almost impossible to have osteosarcoma in both knees. So under those circumstances, I worry a lot less, maybe work up the patient less, because I think it's very hard to have a serious, surgical, or concerning etiology for anything that is bilateral. Statistically speaking, serious injuries, serious complications, serious etiologies are more rare and therefore are unlikely to be on both sides. Rule number 119. Lay down the plan. So this is a good idea and a good rule to practice with your parents. So oftentimes when the parents come in with chief complaint X and I'm about to work up their child, there's a certain plan that has to be put in place. If the child's symptoms are X and I do test Y, what happens if the test is positive? What happens if the test is negative? Laying down the plan with the parents can save you a lot of time later if you do it right after examining the patient and telling them what's going to happen today in the ER. So for example, most commonly I do this when the patient comes in with sore throat. I explain sore throat is usually an infectious problem and you can have two types of infections. It can be a virus, it can be a bacteria. We're going to do a small test, mom and dad. It's called a strep PCR or rapid strep. If that test is positive, little Johnny has bacteria in his throat. He's going to get antibiotics and he's going to be fine. However, if that test is negative, he probably has a virus in the throat. In that situation, unfortunately, there's no specific medication we can provide. Please make sure you give him pain medication, keep him hydrated and comfortable, and this will all be resolved in a few days. I find that if I lay down the plan after examining the patient and telling them what I'm going to do, I save a lot of time for later. The parents are happy, everything is clear, and when the test is back, I can just discharge the patient with or without antibiotics. This is also a good idea to do with your trainees that you work with in the pediatric emergency department. So oftentimes when my resident presents a patient, I ask them for an assessment and plan, and I always ask them about laying down the plan ahead of time and give me a plan if their workup is negative or if it's positive. So for example, if an 8-month-old comes to the ER with what looks like fussiness or maybe what parents think is abdominal pain, we're going to get an ultrasound, make sure there's no intussusception. And if the ultrasound is negative, maybe we'll get a KUB to look for constipation and provide enema. Maybe we can just reassure the parents and send them home. But I make sure the resident is aware of the plan. What are we going to do if that test is positive? That's usually easy because there's a certain something to deal with. Or what are we going to do if the test is negative? In that case, we're going to do XYZ. Laying down the plan with the resident helps me save time later because the resident knows what's the next step if the test is negative and we don't need to rediscuss it. In a situation where I have several trainees or a medical student to work with on a different patient, it often saves me a lot of time to make sure the resident is aware of what are we going to do with X, what are we going to do if Y. What are we going to do if the test is positive? That's usually easy. What are we going to do if the test is negative? What anticipatory guidance are we going to provide? Are we going to send home with any medication? This way there are no questions when the test is back and everybody is on the same page. Another good example, when I work with a trainee and we worry about abdominal pain that could be secondary to appendicitis, so I may say something like, let's work up the kid for appendicitis. If the ultrasound is positive, that's easy, we're going to call the surgeon and do X. If the ultrasound is negative, but the CBC and the lab workup is concerning, let's go ahead and call pediatric surgery to come and consult us if they think this patient needs a CT, observation for serial abdominal exam, or discharge. And again, this way, when the ultrasound and the lab results come back, the resident or the trainee knows exactly what to do next. I personally find that this saves a lot of time for later. Again, the ultrasound is back, and the resident knows exactly what to do next. We don't have to rediscuss it, and I can go ahead and see my own patients or work with a different trainee, the medical student, etc. So remember, rule number 119, lay down the plan. Do it with the parents about the workup of their child. Do it with the residents about the workup of their patient. And that is it for today, guys. Thank you very much for listening. Please remember to check PEMRules.com and see how you can contribute to our educational project. You can also check out my column at epmonthly.com. I hope you enjoy reading it. This is one of my favorite songs to play by Queen. This is the ukulele version. There are actually 4 different types of ukuleles in that song. I can't take any credit for the drums. That is by GarageBand. Hope you like it.